let's go into it. And then look at anxiety disorders. Okay. Now, I always begin this by saying that when it comes to anxiety, anxiety is just something that we all experience it in our daily life. Okay. Everyday life situations or life activities bring a certain level of anxiety within us. But what makes one form of anxiety abnormal is how long the anxiety is going to persist, and then how long the anxiety is going to persist, and then how we manage the anxiety. That is what makes it to be a normal anxiety, or what makes it to be an abnormal anxiety. Okay. And so anxiety is a normal response to stress, just like the exam we are preparing to go and write. There is no one who is here. For those who have just like a week or let's say a month or 2 months to their exam can attest to what the level of anxiety they have in them, especially my students. Some of them will come in, I'm anxious, I have a week or so to go and write my exam. Then I'll be like, it is normal. Okay. If you are writing this exam and you don't have a certain form of or a certain level of anxiety within you, then you are not a human being. Every human being has a certain level of anxiety that a person experiences. So anxiety is a normal response to stress. It is a subjective feeling. I cannot tell how someone is feeling if the person is anxious, or you cannot tell if someone is anxious unless the person opens up to you, okay, and that I'm anxious, and because of my anxiety level, I'm experiencing so. So anxiety is more subjective experience that include feeling of apprehension, uneasiness, uncertainty, and dread. So the uncertainty of the exam you are going to write as to whether you pass or you fail brings up a certain form of fear within you. And so that is what anxiety talks about. Now, it occurs as a result of a threat that may be misperceived or misinterpreted, or a threat to oneself, a threat to one's identity or self-esteem. So let's say you are going to write exam and you have some level of fear in you. You don't even know the outcome of the exam. So sometimes you think, am I going to fail the exam, or am I going to, pass the exam? Now, if there is also a threat to identity, let's say that, someone approach you, someone attack you, okay, physically attack you, that, an armed person trying to cheat you or trying to, steal something from you. And that kind of threat that comes to you can bring certain level of anxiety. And then you start to, panic, you start to we looked at the various levels and the assessment findings of some symptom the person will be, showing. But generally, if there's anxiety, the person will be panicking, panting, you see that respiratory rate will go up and all that, okay? So those are some of the things that will happen with regards to anxiety. Anxiety may also result when values are threatened or preceding new experience, okay? And I always say that, like, we are, preparing to go and write the NCLEX and one day go to the US. As we are here preparing for the exam, the moment you get to the US, definitely there's going to be some form of anxiety, because you are now coming to face new challenge, new experience. You start asking yourself, how are you going to cope with it? You start asking yourself, how are you going to cope with the anxiety? Now, all these things can spark some kind of fear within you, okay? Especially when you are going to face new challenge or new experience, or you have changed your workplace, you are going to a new place. As you are going, the moment you step foot there, your first day at work, people will be asking, who is this person? And then you start having some form of fear within you, okay? And that is what anxiety comes about, how anxiety comes about. The types of anxiety we have normal, acute, and pathological. The normal is what I'm just talking about, where change of environment can bring or can spark up issues. And then within some few minutes or few hours after familiarizing yourself with the people, you get used to the area and then you start coping. That is normal anxiety. However, acute anxiety mostly results when there is an imminent loss or change that threatens one sense of identity. So let's say you are approached by an armed robber, the person points gun on you, and then you are panicking, you are panting. So that is the kind of anxiety we are talking about, and that is what acute anxiety. Anxiety that is precipitated by imminent loss or change that threatens one's sense of security. Okay. Or there is, let's say, earthquake has occurred in your area just all of a sudden, and then you don't even know your whereabouts or what to do. When that happens, you are going to experience some form of, anxiety, and that will be what? Acute anxiety. Now, when it comes to the next one, which is pathological. Pathological occurs when the intensity of the emotional response is out of proportion to the threat, and mostly with what we call pathological anxiety. The person continues to experience those emotional responses even after the threat has been resolved. Okay, even after the threat has been resolved, the person continues to experience that kind of fear. Okay. That kind of fear, the person continues to experience that kind of fear, okay, within the person. And that is what pathological anxiety is about. Okay, even after the problem has been resolved, the person will still be experiencing what we call some form of fear within the person. The emotional response become generalized to benign situations. Okay, so issues that do not even demand anxiety, you see that the person will be panting, the person will be experiencing some form of fear. Okay, that is what pathological anxiety is about. So that is on pathological anxiety. We also have levels of anxiety. So we have types. The types are normal, acute, and pathological. Then we have levels. So the levels, that's where we have mild, moderate, severe, and then panic. So those are the levels of anxiety we have. We have mild, moderate, and then severe to panic attack. So that is the levels of anxiety that one can experience. Remember, we said the types are three: normal, acute, pathological. Now let's look at the levels. The levels we are talking about mild. So the mild situations are what we experience in our daily life. Going to write exam, you are having some kind of fear within you, or change of work environment, new experience brings up some kind of fear within you. That is what we talk about when we are talking about mild anxiety. So mild anxiety is associated with tense experiences that occur in everyday life situations. It increases one's ability to grasp information. So when you experience a mild form of anxiety, it pushes you to, grab more information or to learn more. So for instance, you are going to write exam, you fear that you fail the exam. And so because of that, you do what? You put in more effort by learning so that you can pass the exam. The same thing when you are going to a new place to learn. The moment you step foot in the facility, you put all efforts that you need to put together to be able to succeed. And so mild anxiety increases one's ability to grasp information. Due to that, it also, increases one's sense of sight and sound. So that, you open your eye, your sight, everything will increase. I hope you get it. It also increases one perceptual field. So perceptual field is also increased here. It can be motivating. So it motivates you to do more, so that it will produce a certain level of growth in you, so that as you are going to write the exam, that fear that you have or that level of anxiety you have will motivate you to learn more, so that you pass your exam and then you grow in your profession. I hope you get it. So it helps one to, it produces, or it can be motivating, produce growth, enhances creativity, and then increases learning as well. So these are some of the things that mild anxiety causes one to do, or mild anxiety can lead to. The physical symptoms that one will show when the person is experiencing anxiety, mild anxiety, is what? Restlessness, irritability, or mild tension. Okay, just the moment you step foot in your exam hall, see some kind of tension within you, some mild form of tension, and that is what mild anxiety is about. We'll look at the management very soon. Then we talk about moderate. So meaning that moderate will be a little bit severe in terms of, the problems, or in terms of the severity of the anxiety the person will be experiencing. So we have moderate anxiety. The focus with regards to, the focus is on imminent concern, or sorry, immediate concern. So at this time around, the problem is more worried. Okay. So let's say you are faced with, a certain bad problem. Like, let's say you have been attacked by, an armed person, or an armed robber, or someone threatening to come and rape you. Okay. Forced to, rape you or something like that. So that is what mild or moderate kind of, anxiety can cause. So the focus is most immediate concerns. Here we said that in mild anxiety, one perceptual field increases, but then in moderate, the perceptual field rather get narrowed. The sense of sight and sound also diminishes as selective inattentiveness occurs. So at that point in time, the fear increases. And so as the fear also increases, your ability to even pay attention also decreases. And so that decreases what we call your sense of sound, and then your sense of what we call sight as well. And so at that moment you fear, you don't even know, where to even pick something to even try to defend yourself. Are you getting me? So that is what moderate anxiety can occur. In moderate anxiety, learning and problem solving, abilities can still occur, but not as compared to in mild anxiety, where you are more open to information, where you can solve problems and then your challenges. But in moderate anxiety, learning and then problem solving still occurs, but not as compared to that of mild anxiety. The physical symptoms that occurs here are that there's going to be one heart rate going to increase. So it's like sympathetic, nervous system will be activated. And so you have heart rate increasing, there's perspiration, almost everything within the person goes up. So there is increased heart rate, perspiration, gastric discomfort will also occur. The person will start complaining that I'm having abdominal pains, I'm having this. One thing that mostly happens here is that you see the person wasn't having any full, rectum. But the moment that situation happened, the person will become, I want to go and eat myself. And so that is what happens here. Okay. You go and then, nothing is even coming out. So there's some form of gastric discomfort that can occur. There's headache, urinary agency. You want to go and free yourself, even though before that incident, nothing, you weren't having a full bladder. But the moment, that form of fear set in you, you now want to go and then, free yourself. Then we have some mild tremors can also happen. And so that is with moderate form of anxiety, or what happens during moderate anxiety. I believe we are taking note with the various levels and the differences, and then the physical symptoms that each level presents with. Then as the problem continues, or as the level of fear increases, then that means that the level will also increase. So we have severe anxiety. So this time around, severe anxiety is a feeling that something bad is about to happen. Something bad, the worst form of situations about to happen. Okay, it can be that you are losing your life. It can be that you are, there's some form of fear within you that you are to lose, a relative. It can be yourself or a property. Something bad is about to happen to you, sorry. And so that kind of fear that comes within you, if you start experiencing, that something bad is about to happen to you, that is what, severe, that is when we can classify that form of, anxiety as being severe. There is a significant narrowing in the, perceptual field. Focus is more on minutes or scattered details. Okay. And so, the person I mean, the focus is more on scattered details. Almost everything. I mean, within, let's say something bad is about to happen, let's say an earthquake. I mean, there's a warning that something like that is about to happen. Within minutes, you want to, I mean, gather as much as things you can gather within the, I mean, that's little time you have. So that is how the focus is more on. So the focus is more on minutes or scattered details. You are not able to even focus, okay, let me pick this, let me break these things together for, I mean, whatever it's approaching me. Then all behavior is also aimed at relieving the anxiety. So at this point, because the fear, it's too much, you want to bring every effort or whatever you can do to solve the problem. Okay. So let's say you have a relative who at a point is just about to die, and let's say you are the one taking care of the person and you are with the healthcare team. You want to do everything. You want to put all your effort together to save the person, especially if, let's say, the person is a very young person, very dear to you, and then, I mean, you see that this person is just about going. At that point in time, whatever effort you have to put in place, even if you don't have the money, and then you have to go and borrow the money from whoever you have to go and borrow, you put everything together to try to, I mean, salvage the situation. So all behaviors aim at relieving the anxiety. Then learning and then problem solving are not possible at this point. So when it gets to the severe anxiety, you are not able to think enough, you are not able to reason that much to be able to solve, I mean, problems. Okay, so at that point in time, you might even need assistance so that someone will come in to also help you solve the challenge that you are facing. Actions are aimed at reducing or alleviating the anxiety, just like I said. I mean, at this point, you put in all efforts in order to reduce or, I mean, salvage the situation, or, I mean, alleviate what you call the anxiety. The symptoms that people experiences during what we call severe anxiety is that the physical symptoms mostly, I mean, as a result of stimulation of sympathetic nervous system, there's going to be headache, nausea, dizziness. I mean, there's also sleep disturbances, okay, and then increased tremors, pounding heart rate, okay, heart rate occurs. So it's like almost all the, I mean, symptoms that someone experiencing mild anxiety would experience. But this time around, the severest form, okay, so heart rate increases in what? In moderate anxiety. But here we are saying that pounding heart rate. So when you try assessing the heart rate, you see that the heart rate will be, I mean, in terms of the pulse strength, will be what? Will be very, very, very high. It will be pounding heart rate, and then hyperventilation. So that is why when you do ABGs, okay, you say that someone is experiencing severe form of anxiety. What form of, I mean, arterial blood gas analysis you expect to see? Because of the hyperventilation, you say the person is bringing more carbon dioxide out, and we know that carbon dioxide itself is what is it's acidic. So if you are bringing more carbon dioxide out, it makes your carbon dioxide level goes down, okay, within you, and then that could lead to, I mean, respiratory alkalosis, right? That's going to lead to respiratory alkalosis, okay? So if you have not learned about ABG, sorry, if you are not learning about arterial blood gas analysis, don't worry. I mean, you learn it and then you get to understand what I'm talking about. I mean, there are questions that you see someone is having a certain level of anxiety and then it's hyperventilating. What form of, I mean, arterial blood gas analysis you expect to see with the individual. Okay. Then you also have the individual needs direction to focus. So at this point, you might need to direct the person in terms of what to do and then how to go about it well during what we call severe anxiety. Then the last form or the last level is what? Panic anxiety or panic level anxiety. And so at this level, the panic is more associated with fear and terror, or dread and terror, and a sense of impending doom. Okay, so that is a worst form of situation, and that can happen to an individual. At this point, the person is panicking. There is disorganization, difficulty perceiving reality, and inability to concentrate. So when someone is experiencing a certain form of anxiety that leads to panic attack, then the person will not even be able to concentrate and to be able to perceive what the real reality is, and for the person to be able to also, solve problems. So inability to concentrate will be affected. There is loss of rational thoughts with distorted perception as well. So at this point, the person cannot even perceive the ideal, reality, as well as, there's loss of rational thoughts with what we call distorted perception. And so if the thing is even, let's say, what we call a stick that is lying down, because there's the perception has been affected. The person might even think that what is lying down is what is a snake. So that is what we call, when it comes to loss of rational thoughts with distorted perception. And so the person is not able to, come into reality to what is actually the ideal problem. Okay. Then the individual is not able to communicate or function effectively. And that is where it becomes a problem, because the person has lost the ability to concentrate. The ability to communicate will be affected, as well as how the ability to function appropriately will also be affected. If prolonged, panic can lead to exhaustion and death. So if someone continues to panic and then the person is not attended to, care is not provided, Madam Anita, I'll call you, I want to land, okay? Then I'll call you so that you come in. The person is not able to get the needed support and help, the person can even end up dying with regards to, panic attack or panic level of fear or anxiety within the person. There is increased motor activity. So during panic attack, you see that the person will be panting more, the person will be pacing, shouting, screaming for help, okay? Or the person might withdraw. So the person becomes more sober or can become more sober. So increased motor activity can occur. And then with the increased motor activity, that the person will be pacing, shouting, and then screaming for help, or there's going to be withdrawal. So the withdrawal, they can become more sober. Okay. At that point, it's not more about increased motor activity. They are not even able to move at all, and then they become more sober, like someone who is depressed. Then we have impulses and then impulsive and then erratic behavior. At this point, the person start to behave abnormally. Okay, impulsiveness and then erratic behaviors can all happen as well. So yes, I saw a hand up. Madam Anita, your hand was up. Yes, so I think I have to unmute you, right? Yes, I think I have to unmute you. So let me unmute you so that you can.
So in relation to the example you made, can we say that a person who has
example
concerning the snake, when you're talking about the panic, so
Mhm.
can we say that someone who has panic anxiety is also paranoid?
Paranoid.
Yes.
Oh, with a well, so you want to know whether panic anxiety can, yes, they when it gets to panic, okay, the paranoids, their problem is more of trust issues and those kind of things, okay.
Okay.
So that is more of a personality disorders or personality issue, okay. So I don't want to say that if someone is panicking, a person becomes paranoid, okay. At the point the person can become paranoid, of course, the behaviors can be affected. So the person's ability to even trust someone can also be affected. So yes, it can lead to, a paranoid form of behavior where the person might not even want to trust an individual. Okay.
Okay. All
So in
right.
a
Thank
way, it can lead to it. Okay. But
you. All right.
paranoia, or paranoid is a problem of its own. That is more of a personality disorder that we'll talk about it very soon. But yes, when they start to have those abnormal behaviors, the person can, it can affect the person's ability to trust someone else. That can lead to paranoia symptoms or behaviors.
All right. Thank you.
Okay. So let's see what we have. So let's look at, we've talked about anxiety proper. So we looked at anxiety types, levels, and then we have to look at how to manage someone with anxiety. And so when it comes to anxiety, some of the things that we need to think about is one, establishing trust. Every effort that you need to put in place should be something that brings the person like safety. Okay, always stay with the client, let the client trust you, and then avail yourself to the client as much as possible when you need to be available to the client. So you need to recognize the client's anxiety. So recognize the client or the anxiety. You need to establish trusting relationship with your client. Okay, then you protect the client. So all efforts should be that it is something you are doing to protect the client. So establish trust, protect the client. Protecting clients means that you being available for the person. Whatever is causing the anxiety, you try to let the client speak about it, talk about it, so that whatever you can do to stop or to solve the situation or to solve the problem, you must do to do it so that you prevent, the person from experiencing further anxiety. Then you need to modify the environment. So modifying the environment has to do with setting limits or limiting interaction with others. So at this point, the person has some bit of fear within the person. So you might need to protect the person, limit the number of people who even comes to see the person, even though, family members should be allowed, but you have to set some form of limit with regards to what we call client interaction with other people. Then coping mechanism. Okay, understand that we learn about the various types of coping mechanisms or the coping mechanisms. Okay, so you have to understand that it is during anxiety that clients will employ what we call those coping anxiety as coping mechanisms. Okay, so do not criticize coping mechanism. If someone is experiencing displacement after having encountered a certain challenge, don't go and criticize. Why are you doing that? Allow the person to pour their issues out. After pouring the issues out, they will become normal. So do not criticize what you call coping mechanisms. You provide creative outlets, as well, to monitor signs of impending destructive behavior. So we said that people with panic level of anxiety can experience some form of erratic behavior or impulsiveness. And so because of that, you need to assess for any form of abnormal behavior that the person will show up. You provide relaxation techniques such as breathing exercise or guided imaginary. So for people experiencing anxiety, you need to engage them in some form of relaxation exercise, like the breathing exercise. Remember, we said these people will be hyperventilating. So you need to be available so that you take the person through some form of breathing in exercise, like breathing, hold, and then they relax. I believe we've all done this, like when your child is crying or there's some form of anxiety in your child, you tell the person, take a deep breath and then bring it out. Take a deep breath and bring it out. So that is what those relaxation techniques is about. Then you monitor vital signs. Administer your anti-anxiety medications. Now, our anti-anxiety medication or anxiolytic that we all know, they are the one, benzodiazepines. Okay. I remember I did pharmacology not long ago. I think last month or two that I did pharmacology. And I talked about psych medication. So I mentioned all these things that when it comes to anxiety, we use the benzodiazepines. The benzodiazepines example is aprazolam. Example also is diazepam and all those pam families. Okay, they are anxiolytics, or they are medication generally used to manage what we call anxiety, even though they are used for other purposes that we all know we use in our facilities. But typically, that is what we use what we call the benzodiazepines for. When you are giving back benzodiazepines, one thing you need to watch out for is that you need to watch out for people who are dependent or who abuses medication, because benzodiazepines can easily be abused. And so when you have a client taking a benzodiazepine, or a benzodiazepine is to be prescribed to a client, and then you realize that the client is a drug abuser, you need to report that to the healthcare provider, because the client might end up abusing the benzodiazepine. And so that is one thing I just want to chip in here. you need to also, you do not force the client into situations that provoke the anxiety. One of the things is that you need to expose the client to their fears so that they will be able to cope with their fears and live with it. But if the client is not ready to face their fears or to, face their challenge, the thing is that do not force them to go near their problems or to go near their fear, whatever is provoking the anxiety. If the person is not ready to talk about it or the person is not ready to face it, do not force the person unless the person is ready to face that challenge or to face that, fear. That is when you allow the person to go near it and learn and then try to cope with it. So the immediate nursing action for a client with anxiety is to decrease stimuli in the environment, provide a calm and a quiet environment. So I said that safety is key. And we all know that the exam we are preparing ourselves to go and write is a safety exam. Okay. And so when someone is experiencing anxiety, the key is to ensure safety by minimizing any form of, unwanted stimuli in the client's environment, making sure the client's environment is calm and then quiet as well. So that is what happens generally when you are caring for someone with what we call anxiety. Now, when it comes to the interventions for the various levels, we looked at mild to moderate. In fact, all the interventions here, all the things I just talked about, they are here. But just that at this time, I have just classified them, or I've just grouped them into moderate to mild to moderate, severe to panic levels in terms of what we call the management. And so with mild to moderate, you need to help the client identify their source of anxiety. You encourage them to talk about their feelings and then their concern. Remember, we said in mental health, always allow the client to speak or always allow the client to talk if the client is ready to talk. You help the client to identify the thoughts and feeling that occurs before the onset of the anxiety. And so before the anxiety, you have to let the client whatever the client was thinking about or whatever thoughts the client was having before the anxiety, you have to let the client try to identify them, encourage problem solving, and then encourage gross motor exercise, okay? Helping the client to walk around, helping the client to engage in some form of gross motor activity will help the client to alleviate what we call their form of anxiety. It kind of takes them off what they are thinking or their fear. And then the severe to panic level, what we call anxiety, you need to use a calm manner. You need to be calm when you are talking to your client. You need to be ready for your client, avail yourself for your client. Make sure that your environment is calm and quiet without any form of disturbances in terms of environmental stimulation. Then always remain with your client. Remember, someone experiencing anxiety, we don't leave the client, especially if it is from severe to panic. Okay, we don't leave the client alone that I'm going to do this, someone else, or I'm going to do this, or I'm going to inform the healthcare provider. Get someone to inform the healthcare provider. Minimize environmental stimuli. Provide clear, simple statement. Remember these people, we said that when they are experiencing severe anxiety, their problem-solving skills get affected. And so their ability to grab information will be affected. And so you need to provide them with clear and simple instructions. Do this, stop here, don't go here. Do this, do that. That is all. Don't try to bombard the client with a lot of information if someone is experiencing severe to panic level anxiety. You need to use a low pitch voice when talking to the person. Attend to the physical needs of the person. So the physical needs could be bathing. So activities of daily living will all be affected because the person will not be able to pay much attention to themselves. So you need to help the clients with their physical need as well. You provide them as well with gross motor activity, such as walking, pacing with you, the nurse, and then you assess their need to administer medication. So the same thing, your anxiolytics will be needed here. Safety is the key when you are caring for these people. You always have to make sure that you are providing them with safety and ensuring that their environment is also safe as well. So that is what we call anxiety itself, and then the levels, the levels. Now, when they were not able to help the client solve their problem, or someone, experience anxiety, and out of it, the problem persists for more than 6 months. If the problem persists for more than 6 months, then we now term it as general anxiety disorders or general anxiety disorder. So general anxiety disorder occurs is when unrealistic anxiety about everyday worries persists more than 6 months. Okay. When the anxiety persists for more than 6 months, then we say that it is now general anxiety disorder. It is now a disorder itself. Okay. Not just an anxiety that can be resolved within some few days. It is, and then this form of anxiety is also not associated in any form of underlying medical condition or another mental health problem. You know that if someone is having a certain medical condition, let's say you have how do you use, like, let's say DM, you are managing the thing every month, you have to go for your medication, or HPT, a young guy, you have been diagnosed with HPT around, let's say 25 years. They say that you have hypertension. Now that form of, the condition can spark some form of anxiety within you. And because such conditions are also chronic, it means that that fear about the condition can even persist for long. So if the anxiety is about the problem, the medical condition you are having, then it is not a generalized anxiety, because we have the actual cause of your anxiety, which is as a result of the medical condition. Or let's say you have a certain mental health problem, and the mental health problem is causing you to experience some form of anxiety, and it has for 6 months. And the problem is because you have that mental health problem. We don't say it is general anxiety disorder. So general anxiety disorder should not be associated with another mental health condition or medical problem. The problem is more of like everyday problem that can spark anxiety, and that anxiety persists for more than 6 months. When that happens, we say it is general anxiety disorder. You cannot just say someone is having general anxiety disorder unless the person is showing some symptoms, or the person is experiencing, yes, some form of symptoms. So we looked at the symptoms for you for classifying someone's anxiety as being generalized, as being general anxiety disorder. So the criteria for general anxiety disorder is that excessive anxiety or worry about several events or activity for more than 6 months. So if you are worrying about certain problems, like everyday problems, for more than 6 months, you are not able to cope with it, okay, and it's past 6 months, you are still experiencing that form of fear. That is one of the criteria for one to be classified, or for one to be diagnosed as having general anxiety disorder. So if someone falls within that, you take the box that, okay, it is one of the criteria. Then inability to cope with anxiety. So as for you, dear, you are not able to, something that you have experienced before, when you are about to experience that same thing, you still go into anxiety, and the problem will keep persisting, and then your fear will keep persisting. So people who are unable to cope with normal everyday life activity in terms of the anxiety, that is also another criteria. Let's say you are traveling, and then for you, anytime you are traveling, you have some form of anxiety within you, or you are anxious anytime you are traveling. But an normal circumstance, after traveling for, let's say you've not gone, you've not had or you've not traveled a very long journey before. After your first experience, the next one should not cause any form of anxiety within you. But as for you, anytime you are going for any form of long journey, it sparks some form of fear within you. You are not able to cope with that. And so that is also another criteria that can be based on to say that, or we can base on to say that you have what we call general anxiety disorder. Then we have another anxiety associated with 3 or more of the following symptoms for more than 6 months. And so if you're also experiencing anxiety and you are experiencing the symptoms I'm coming to talk about for more than 6 months, we only need 3 of it to be available. If you are having 3 of these symptoms within you for more than 6 months after experiencing anxiety, then it is also another criteria for us to classify you as having what we call a general anxiety disorder. So we have feeling restlessness or on edge. So you are always feeling restlessness, and that has persisted for more than 6 months. Okay, after experiencing that anxiety. Okay, so that is one box. Then easily tired. You get easily tired. The small thing you do, which was associated with that anxiety that you experience, you start complaining that I'm tired, I'm tired, I'm tired, easily get tired. If that also persists for more than 6 months after that, anxious experience that you have or you had, or after that anxiety, okay, you easily complain of getting tired and it has persisted for more than 6 months. It is also another thing that we can take. Then poor attention span. You are not able to pay attention, and that has also persisted for more than 6 months. Irritability, muscle tension, difficulty sleeping, that is insomnia, or difficulty falling or staying asleep. These are the symptoms that one has to show for the person to be said to be having what we call general anxiety disorder. And remember, we said that at least 3 of these symptoms must be available, and not just available, must have stayed with the person for more than 6 months after experiencing or after that encounter that caused the anxiety. So these are the symptoms. 3 of these things must be available, okay, for the person to be said 3 or more to be having general anxiety disorder. General anxiety disorder also causes, or anxiety causes, significant distress or impaired ability to work or maintain relationship. So for these people, or for this level of anxiety, you are not able to even cope or work and maintain what we call, relationships. There is no issue of like the person is using drugs, or there's no concurrent use of drugs or abuse. So just like I said, there is no history that the person has an underlying mental health problem. That is why the person is experiencing those forms of issues. Or there is no underlying medical cause or medical problem, and then not explained by another mental health problem. So I've explained all these things. That any form of anxiety within this framework I've talked about means that the person is experiencing general anxiety disorder. The assessment findings or the symptoms you expect to see will be that the person will be restless, and then inability to relax. There's going to be episodes of trembling and shaking. Okay, you are always shaking for past 6 months after encountering the situation. You are always shaking. Okay, and then chronic muscle tension. Then we have dizziness. It can also lead to dizziness, inability to concentrate, and that's the reason why the person will not be able to function and even maintain relationship with other people. Chronic fatigue, sleeping problems, that is insomnia, and the inability to recognize the connection between the anxiety and then the physical symptoms that they are experiencing. The client is also more of, the client is focused on the physical symptoms rather than, the anxiety, or rather than what is causing their anxiety. So they are more focused on their physical symptoms than, what is actually the main problem. They do not pay attention to that, but they tend to attend more to their physical symptoms that they are experiencing. I think I have, with the intervention, it's the same thing. You have to remain with your clients. You attend to their physical needs, how to do with them, activities of daily living in terms of diets. For these people, mostly we say that you provide them with easy to go with food, or easy digestible food, or foods that the person can easily manage, like finger foods. Okay, I believe you've seen those options, and that provide the person with a finger food. So finger foods are things that like the person will just pick and then be eating, like biscuits and those kind of. For these people, sometimes they don't even want to sit and then eat as well. Then assess the client to change the unrealistic thoughts that they are having. Okay. To a more realistic thought, you assist them to identify the thoughts that arouses their anxiety. When I land, those of you with questions, I'll call you. Okay. I want to land with my interventions, then I'll call you. You assist the client to identify the thoughts that arouses the anxiety and identify the basis for these thoughts. So for these people, you have to sit down with them, try to understand what mostly precipitates your fear or what mostly precipitates your anxiety. When you identify it, try to work around it so a client can cope with that kind of problems. Then you have to use cognitive restructuring to replace what we call the distorted thinking. So that is where you have cognitive therapy, so that the clients will go through what we call cognitive restructuring, so that the clients can manage their distorted thinking. Then it is anxiety. So you give your anxiolytics or your anti-anxiety medications, benzodiazepines generally, to help manage their fear. So that is with regards to general anxiety disorders. And then yes, madam, you can come. I'm here to do PTSD. So the one who was asking about PTSD and the difference between general anxiety disorder, I believe that by the time I'm done with post-traumatic stress disorder, you understand what the difference between the two. So just stay calm. After PTSD, you get to understand what it is, okay, or the differences. So, Madam Amma, I will mute you so that you come. Hey, today the way my boss did the meeting here, I have to meet people. Yeah, so can answer your question, madam?
Hello.
Yeah, go ahead.
Hello.
Kindly
So
go ahead.
I came across this anxiety thing this morning, and I wanted to find out at what point does it become PTSD? Because they said that
At what point?
at what point does this anxiety develop into a PTSD? So, but then I'll wait. When you are done with the PTSD, then if I have any questions, I'll come in. Because this morning, they said after anxiety, you experience something and then you become anxious. But after a certain point of time, it is termed as a post-traumatic stress disorder. So I'll just hold my horses and then finish with the PTSD. Maybe I'll get my understanding.
Okay, all right, thank you.
Thank you.
So you are the same person who kept it on the chat box and okay. All right. Okay. So let's look at PTSD. Of course, it is when the person is not able to manage their anxiety. Okay. Now, PTSD, it's a problem of its own. You need to be experiencing certain things before we say that this person is experiencing PTSD, like re-experiencing the problem, like flashbacks. Okay. If you are not experiencing flashbacks, those are the cardinal findings for we to say that someone is experiencing what we call post-traumatic stress disorder after encountering that uncomfortable situation. Like, let's say you've had what we call someone has attempted to rape you. Let me use that. Or, okay, let me use accident. Okay, let me use accident. Let's say you've had an accident. After encountering that uncomfortable situation, of course, you are going to experience what we call some form of fear is going to come within you. And so you don't want to even travel at all. That is what we call anxiety. But if you are there and then all the time you keep on remembering, having a flashback to the accident you had, what happened during the accident event, and because of that, you don't even want to go near, car again. So you tend to have what we call a flashback of whatever happened before the accident. And due to that, you don't want to even go near, car again. You don't want to travel again. Okay. So after experiencing a psychologically traumatic event, the individual is prone to experiencing the event and have a recurrent and intrusive dreams or flashbacks. Okay, so the key words here, okay, for PTSD, for those of us who have had questions on PTSD, I believe you know, you can't get a question on PTSD and they won't talk about flashbacks. They won't talk about re-experiencing of the event. Definitely those things will pop up in what we call PTSD. So your anxiety now becomes PTSD when the problem that caused the anxiety, you keep remembering the problem, or you keep having a flashback of the event that occurred during what we call, yes, that occurred. That is when we say that you are experiencing what we call, post-traumatic stress disorder. So after encountering a certain form of, a bad emotionally or psychologically traumatic event, when you are there, you keep remembering about the event, how the event occurred, to the extent that it can affect your day in, day out activities. So when it starts to affect your day in, day out activities, that is when we say that you are experiencing what we call post-traumatic stress disorder. Now, like I said, the problems or the causes of it are normal or usual problems that one can occur or one can experience every day. One can experience in their life, like let's say accident. We all take car. Nobody prays that someone will get a road traffic accident, which will not happen. But you know that it can happen. And so when it happens, and then after that encounter, whenever you are there, after some time, you start to, re-experience within you. It's not like you have physically experienced the situation, but within you, you start to think about it. Or someone has attempted to rape you or rape you. When you are there, then you will now start thinking about that rape that occurred to you, to the extent that it can affect, your ability to function and your ability to work. Okay. Then we have natural disaster. So the natural disaster, it can be flood. Okay, like in your house or in your community, there was a flood, and then all your property, okay, was washed out, and so you've lost everything. When you are there, you start to think about that event that occurred to you, to the extent that the event, when you start thinking about it, it develops some form of fear in you and then affects your day in, day out activities. Then we have terrorist attack. So those of us who have experienced Boko Haram before, okay. So those who have experienced, terror attack before, those people can experience how bad it is and how they can, when you are there, you can be experiencing those events again. Then we have combat experience, we have accidents, we have rape, we have crime or violence. Okay, let's say in your community, there's been this bad violence that a lot of people have died, to the extent that you yourself, maybe your relative or you lost a loved one out of it. When you are there, you can start to think about it, or you could be having a flashback to that event, and that will affect you or cause some form of emotional trauma. Then we have sexual, physical, or emotional abuse. All these events can lead to what we call post-traumatic stress disorder. So PTSD is more associated with these things. These are the possible causes of post-traumatic stress disorder. For anxiety, it can happen with, let's say, just normal exam you are going to write. But remember here, we don't have exam here. So those are some of the things that you can use to differentiate between an anxiety and then PTSD. Look at the cause. What is causing it? So PTSD causes are more intense or more severe in terms of what leads to the problem. Okay. But even with anxiety, normal daily life challenge can lead you to experience what we call anxiety. And if the problem persists for long and then you are not able to cope with it, definitely you end up in what we call general anxiety disorder, just like I did speak about. So that is with what we call PTSD. When it comes to PTSD, I've talked about the things that you need to see for one to be termed as having PTSD. We said what? The person should be having flashbacks, re-experiencing of the event. So intrusive re-experience of the initial trauma. So that is flashbacks, recurrent nightmares. So when you are going to sleep, or when you go to sleep, you start to dream about that event. Then unwanted, distressing memories. Okay. Strong emotional response when reminded of the traumatic event. When the person is, remembered, okay, let's say you've had an accident. Whenever they talk about that accident that occurred to you, then you start to develop emotional response to it. You don't want it to even be talked about. Okay. So that is with what we call that. One symptom you should look out for with regards to PTSD. You need to, avoiding anything that might cause a recall of the event. So these people try to avoid anything that could cause or that could recall the event. So if it is about accidents, the person fear to even want to travel again. Okay. The person, and then if it's about, let's say, rape, the person even don't want to see a male person because the person thinks like, someone came to rape me, and so it was start to fear. Okay, so anything that will record the event, the person try as much as possible to avoid those things. And then alteration in arousal, that's increased irritability, angry outbursts, exaggerated startle response, sleeping difficulties, and then hypervigilance. So this time around, your eye becomes opened, okay, to every event around you. If it was about rape you experienced, now your eye will be open. If it was like you were attacked by, let's say, an armed robber, now whenever you are alone, you are now, your eyes are now widely open, okay, ready for anything. So you become hypervigilant, okay. And then we have excessive fear. They have some form of guilt, and then they have feelings of detachment as well. So they become more detached from people and all that. It can occur to them also. So these are some of the symptoms that they can experience. I think it's the same thing that is down there with regards to the assessment. So the assessment, I kept it there. It's the same as symptoms. Almost the things I talked about, it still falls here. So things that you should be able to assess with regards to the individual, the symptoms the person will show to you when you see. So sometimes the assessment, you need to go to the person and ask them if you're experiencing this experience, but it generally talks about, symptoms the person will be experiencing. So we said that it's going to be feeling of detachment. So it could be about the avoidance. So they try to avoid situations, they try to avoid crowded places and all that. And then they have irritability or outbursts of anger. I talked about it. There's detachment, depression that may involve suicidal thoughts. So these people could become depressed to the extent that they will be thinking to commit suicide themselves. So depression that can lead to suicidal thoughts or suicidal ideations. We have anxiety itself can happen, fear, okay, because when you start to think about the problem, you start to develop fear. So there's anxiety itself here that can occur with what we call PTSD. There is sleep disturbances, nightmares, flashbacks of the event, hypervigilance. I've talked about all these things in my what we call symptoms I was talking about. General interventions for someone experiencing what we call PTSD. You need to be non-judgmental, supportive as well. You need to do not judge them when they are experiencing the flashbacks and then they become detached and all that. Okay. Do not support them. Don't be judgmental. Assure the clients that their feelings are normal reactions, okay, to the events. So you need to assure them and then encourage the clients to express their feelings. Monitor for suicidal thoughts. Remember, we said that they can experience what we call, depression that will lead to suicide. Okay, we talk about, suicidal, or we talk about suicidal ideations. We talk about depressive disorders, maybe not today, maybe our subsequent meetings, and learn about all those things. So you need to teach the clients about stress managing techniques, how they can manage their stress. Okay, you need to teach about that. Then you assist the clients in identifying and developing adaptive coping and relaxation techniques. So we've talked about the relaxation technique. It could be deep breathing. It could be, walking around or gross motor exercising and all those. So things that the client can engage in so that, as a form of an adaptive coping mechanism, whenever they tend to have the flashbacks, then you encourage them to use supportive group. We know that when it comes to mental health, supportive group are very, very essential in managing mental health problems, where you identify people with similar problems, the clients joins them, learn about their problems and how they cope with their problems. Then you include the family in their treatment as well. Then we also have, engaging in evidence-based therapeutic interventions like medications, like cognitive behavioral therapy, prolonged exposure. That is one of the things that you need to expose the client to their fears. But remember, if the client is not ready to face their fears, don't worry them. Don't force them that change now, go and face your fear. No. When the client is ready to face their fear, expose them to their fear, because the more you expose them to their fear, then they cope with it, they live with it, and that becomes normal to them. And then we have eye movement desensitization and then reprocessing, which is also another, therapy that can also be given to people with what we call PTSD or post-traumatic stress disorder. So that is the end to PTSD. If you have a question, you have an input you want to make with regards to PTSD, can bring it up. The one who wanted to ask the difference between PTSD and then anxiety, I don't know if at this point you now have, a better understanding with the difference between the two. All right. All right. So let's look at phobia very shortly. Okay. From phobia, we'll do obsessive compulsive disorder, and then we'll try and answer some questions. Okay. So I've been talking, I'll finish with phobias very soon, and then we'll try looking at questions as well to also try to better our understanding with regards to whatever we've studied. Okay. Yes. So with phobia, okay. So phobia or specific phobia, okay. So that is an irrational fear of an object, activity, or situation that persists and that leads to avoidance. So this is when someone have a certain fear to an object. It can be a space, it can be a situation, it can be a certain form of activity. So let's say, you fear to talk in public. Okay, so that is phobia. Okay, you fear to sit in public and eat. That is social phobia. Okay, you fear to go to an enclosed space alone. That is phobia. You fear to climb up. That is, a certain form of fear you have. Okay, you fear blood. Okay, as a nurse, you fear blood. Whenever you see blood, you are running away. That is fear. That is why a certain form of fear. You fear animals. Whenever you see animals, you are running away. Even if it is an ant that you spot around you, you are running away. And that is what we call phobia. It is abnormal. Okay. These things are things that, you should be able to cope with them and live with them. But if you are always having fear in you and you are not able to cope with these things, then we say that you are having what we call phobia. So phobia is one, or specific phobias are when you have irrational fear of an object's activity or situations. It is mostly associated with panic level anxiety or fear if the object or situation or activity cannot be avoided. And so for this kind of phobia or this kind of problem, the fear setting if the person cannot avoid the situation. Let's say you have what we call, you fear an enclosed space, and then you've had a condition that demands that we should go and do is it MRI? I think it's MRI that you will put in that enclosed machine, and so because you fear an enclosed space, when we take you to go and do the MRI, you are shaking. You cannot stay inside that enclosed space. And so in that instant, they need to find an alternate way of taking what we call the scan, or taking that, doing that intervention for you. So they employ defense mechanism, and these people, their defense mechanism they mostly employ to manage their phobia or their fear is repression and then displacement. Okay. The types we have, I think I'll just mention them. Those that social phobia is one of the things that we need to know. Okay. Like social phobia, where someone feared to speak in public, someone feared to sit in a public and eat. Let's say, your husband wants to take you out to, a restaurant where you have to sit in the midst of other people to eat. You always want to dodge. You're always giving, excuses, okay, to that. And then you don't want to go out and do that. Okay. That is what we call social phobia. Or let's say you are a head of unit, or you are in charge in your ward, and then you have been called to come and give a report of your ward during general staff meeting. The moment you hold the microphone, you are shaking. Giddy, 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 giddy. That is social phobia. Then we also have claustrophobia. I think that is one of the common one, where the person fear of enclosed space. So the enclosed, they like asking about social phobia, they like asking about claustrophobia. And then I think acrophobia is also one of them, fear of heights. And then we also have aglophobia, which is fear of open space. So whenever they are going to an open space, then they also have fear. Then we have astrophobia, that is fear of electrical storms. And then hematophobia, that is fear of blood. Hydrophobia, fear of water. And then zoophobia, fear of animals. We also have xenophobia, fear of strangers. So these are the various forms of fears or types of fear and phobias that we have. At least we need to know them. We need to know their meanings and then their definition. Okay, we need to know their definition. We need to know them, and then when they are described, we can differentiate between them. When it comes to the interventions for what we call them phobia, you need to identify the basis of their fear or the basis of their anxiety. You need to help the clients to, identify them. Then you allow them to verbalize their feelings. This is mental health. Always allow them to talk about the things that is causing their fear. So allow the client to verbalize feelings or anxiety about the anxiety producing object or situation. Talking frequently about the feared object is the first step in this sensitization process. So when it comes to phobia, when the client says that I fear to go to public to go and eat, don't force the person to go, but try to talk about it. If it is about, let's say, going to sit in the midst of about 100 people to eat, try to expose the person to about, let's say, 10 people. Okay. Then out of it, the person will try to learn and cope with it. So that next time when you take the person to where you have about 100 people seated, the person can confidently sit and also eat. If it is about, let's say, standing in front of a general, like a huge number of people to give a speech that you fear, start gradually from, let's say, a small group of people, then increase the number gradually to the extent that you develop your confidence to be able to stand in front of, a huge crowd to speak. So the first step in helping someone to cope with phobia is by desensitization, that is exposing the person to the fear gradually. Okay. Then you teach the person relaxation techniques such as breathing exercise, muscle relaxation, and then visualization of pleasant situations. You promote desensitization by gradually introducing the individual to the feared object or situation in small doses. So like I said, expose the person to their fear in small doses, not just pick the person that is go and stand in front of 100 people and start talking when you know that the person fears to talk in public. Try to expose the person to a certain small group of people, and then increase the number gradually to the extent that the clients can now deal with, I mean, a huge crowd. Always stay with the client who is experiencing anxiety to promote safety and security. Never force the client to have contact with their phobic object or situation. Like I said, if the person is not ready to talk about the problem or to learn about their situations, never speak about them. Okay. Never speak about them. That is with what we call phobia or phobic attack. Someone was asking about obsessive compulsive disorders, whether it is, yes, it is a personality disorder, okay, but it also falls because anxiety is also part of it. And so it can also be treated as anxiety disorder, because if you stop them from doing that ritualistic activity, it can result in anxiety. So because of anxiety, we don't tell them to stop whatever they are doing, even though I'm here to do, OCD, but I'm just responding to someone who kept a question that is obsessive compulsive disorder, a personality disorder, or an anxiety disorder. Yes, when you are learning about personality disorders, you still come across OCD there, okay, because I mean, it has a certain form of personality issues there. And at the same time, their issues can result in anxiety. And so you can also treat it under anxiety as well too. So that is why. Please, can I have a look at the types of phobia a second? Those who are screenshotting my this is my intellectual property. I'll see you. That's just by the way. Feel free to screenshot. Okay. All right. So that is it. Then let's go into OCD. After OCD, we'll do questions. Okay. Now, under OCD, we all know OCD. Okay. Obsessive compulsive disorder. And the obsessive compulsive disorder, we know what the problems are. These people are more obsessed with what we call, certain form of, thoughts, and then compulsion. The compulsion is where they are always engaging certain form of activity, like hand washing. The moment you tell them to stop the hand washing, then they start to shiver, they start to shake. It results in anxiety. So it is two problems put together: obsessive and then compulsion. The obsessive is you having, a certain form of intrusive thoughts, okay, impulsiveness or images and then ideas. That is the obsession. So you are preoccupied with persistently intrusive thoughts or impulses or images and ideas. So it could be that, as for you, you always want your room to look well organized, okay? And so all effort that you put in place every day is to be sweeping your room, is to be organizing your room, is to be making sure that this thing is kept here, this thing is kept here. The moment someone comes to pick that item and drop it somewhere else, you become angry with the person, okay? And so that is where the personality issues comes in, okay? That is where the personality issue comes in. The moment someone comes and pick that item that you drop somewhere, okay, and then let me say you are married, you have arranged your things. Your husband comes, pick maybe the Milo Konko, drop it somewhere, or the Milo thing, drop it somewhere else to fetch. After that, the person left it there. The moment you come in now, then you start shouting, you start, talking anyhow to that person. So that is where the personality issue comes in. Okay. Then the anxiety also comes in when, mostly with regards to the compulsion aspect, when the person is too, paying attention to certain ritualistic activity, has to do with, let's say, hand washing. All the time the person is washing their hands. The moment you tell the person to stop the hand washing, then the person goes into an anxious state, or the person becomes anxious, anxiety setting. Okay, so compulsion is the performance of ritual or repetitive behaviors an individual is driven to perform to prevent some event, divert unacceptable thoughts, and decrease what we call anxiety. Obsession and compulsion often occurs together and can disrupt normal daily activity. And so most of the time, the two occurs together. You think about the situation, and then the thinking will result in you performing the activity. So the thinking is the obsession. You performing the activity is the what? Is the compulsion or the compulsiveness. Okay, so mostly they occur together, and then the anxiety occurs when one resists obsession or compulsion, and from being powerless to resist the thoughts or rituals. So just like I was saying, the person becomes anxious when the person is told to stop whatever he or she is doing, or whatever thinking the person was having. The moment the person, is told to stop, or the one is preventing the person from having that kind of, obsessive thinking, then the person goes into an anxiety. Obsessive thoughts can involve issues of violence, aggressive, sexual behaviors, orderliness, okay, or religion, and uncontrollably can disrupt conscious thoughts and then the ability to function. So that was where I was using the orderliness. So that is one of the examples I can use to best describe what we call obsessive thoughts. You are always thinking about, let me keep my room clean. Let me keep my room always well arranged. My things, don't come and touch it. Okay, that is an obsessive thought. Then the compulsion is more of the ritualistic activity, which the behavior is to decrease anxiety, and then the patterns are more associated with obsessive thoughts. You think about it and then you perform. The patterns neutralizes your thoughts, and then during stressful times, the ritualistic also increases. And so during points where the person is more stressed up, then the person tries to engage in what we call the ritualistic behaviors, and then the ritualistic behaviors also increases so that the person can manage what we call their stressful situations. The forms of defense mechanism that these people employ are repression, displacement, and then undoing. So someone asked me, what is undoing? Undoing is when you stop that ritualistic activity. That is basically the meaning. Okay, so undoing is you stopping. I know that I've talked about repression, we talked about displacement. And so someone asked me, okay, you didn't talk what we're doing defense mechanism. You didn't mention undoing. So what is undoing? So undoing is the fact that when you are engaging in certain form of activity, or you are engaged in certain form of behaviors, when you stop that behavior, that is what undoing is about. So that is on what we call OCD and its related disorders. Now, when it comes to the intervention, remember, in OCD, we don't tell the person to stop the problem, or to stop the thinking, or to stop engaging in that ritualistic activity. But what do? We tell them to limit the time they spend. So let's say the person is known to spend like 4 hours in always washing his or her hands. In managing the situation, you don't just go and say that, hey, Ofa, stop hand washing, stop your hand washing. If not, I'll beat you. Stop the hand washing by force. Stop the hand washing. We don't do that. Okay. But rather, you have to limit the time the person is spending on the hand washing, and then engage the person in other relevant activities. It could be gaming, or it could be engaging the person in game or other important activity. So if it is 4 hours, reduce the time to, let's say, half the time the person was spending, like 2 hours. Okay, so allow the person to continue their ritualistic activity. However, limit the time that they spend. Okay, so let's go into it. One of the things that you need to also pay much attention to is their basic needs. So their basic needs are food, rest, hygiene. Make sure they are always met. Remember, these people, when they got engaged in those ritualistic activity, they don't even want to stop and eat. They don't even want to take a rest, as well as attend to their hygiene. So it is your responsibility to ensure that those basic needs are met when one is having an obsessive thinking or an obsession and then compulsion. Yes, Madam Sarah, your panel was up. So I have to unmute you. And that me Zoom, you know. Me Zoom setting, how it was done, unless I unmute you. So Madam Sarah, keep your hand up, let me unmute you so that you come in and then yeah, so I
Okay,
think
thank you.
so go
So I
ahead.
wanted to ask, do you have a certain age for the obsessive compulsive disorder? Or does it get to a time that one gets that disorder? Do we have a specific
No, you don't
age
have
range,
age.
or all of a
You
sudden
don't,
it can
it
happen?
can happen to anyone at all, regardless of age. So it's not age dependent.
Yeah, but at a certain point in time, maybe the person was growing up and wasn't having the
Yes, it can
disorder,
happen.
but grew up and then started having it.
Yes, it can happen to the person. So it's not something like you should have it from your beginning of your life. Okay. Now, let me use the cleanliness. Okay. Let's say, as you are growing, okay, now you now become so much, focus on cleanliness at a point in your life. That is why it has now become a mental health problem. Okay. And we do not say it's normal again. Yes, everybody wants to keep him or herself clean. But if for you, and going to, let's say, where from 20 years going, you now started, thinking about how to keep your room neat, and then all the time all your attention is on cleanliness. Yes, so it can happen to you at any point in time. Okay, you could be normal, but at a point in your life, then you now start having the obsessive thinkings or the obsessive thoughts, or you start engaging in those ritualistic activities. That is why it is a mental health problem. So it can happen at any point in time. All right. So I said that basic needs are the key things. You need to make sure clients meet those, those things are met for the client. You identify the situation that precipitates the compulsive behaviors. Encourage the client to verbalize concerns and feelings. Yes, there's another hand, Tina. Let me mute you. Okay. Well, I'm unable to unmute you. It's happening. I did for the other people, but
Please, I want to find out whether the defense mechanisms, there was one that was
yeah, go ahead.
said undoing. Does that mean at a point in time they stop becoming obsessive and compulsive?
Tina, we cannot hear you again.
Hello, can you hear me?
Yeah, go ahead.
I was asking that the defense mechanisms for the obsessive compulsive behavior, there was one that talked about undoing. Let me type it. My network
You
is
want to
bad.
type your
Let me
question?
type it. My network is bad.
All right, so you type it, I'll read it out. Okay, so I'm continuing. When you are done, I'll read it out. Okay. All right. So let's continue. When her question is ready, I'll see what she wants to ask and then we'll try to do it. So you need to be empathetic. You need towards the clients and then aware of their needs to perform their compulsive disorders. Compulsive behaviors. Do not disrupt their compulsive behaviors unless they jeopardize the client's safety. Okay. Yes, we said that. Do not stop the clients from engaging in the ritualistic activity. That is the fact. But if you notice that it is jeopardizing the client's safety, then you need to stop the client. Okay. So you provide for the client safety related to what we call their behaviors. Allow time for the client to perform the compulsive behavior, but set limits, just like I mentioned, that we set limits. We don't let them stop what we call their activity. And then, because when you stop them, it might lead to what we call an anxiety. But set limits on the behavior that may interfere with the client's physical well-being to protect the client from physical harm. Implement a schedule for the client that distracts from the behavior. So you structure activity, basic activity, can be games, it can be any form of useful tasks that a client can be engaging. So you limit the time, you apportion the time, the other time that the client was using for what we call the ritualistic activity for other useful activities as well. You establish a written contract. So the written contract is between you and then the client. That is where you are going to set the limit. So you say that now, you use 4 hours. From now onwards, you are going to use 2 hours to engage in your behavior. And then you use another 2 hours to engage in other forms of activity. So that is the contract between you and the client. So establish a written contract that assists the client to decrease the frequency of compulsive behaviors gradually. You recognize and reinforce positive non-ritualistic behaviors. So you have to recognize, you reinforce positive thinking, okay, that is not related to the ritualistic behaviors. That is where you need to engage the client in other useful activity so that the client can limit the time, use it for those activities, and then cope with their challenges. And so that brings us to an end to what we call the first part of our class for today, and then we'll go into questions to assess our understanding on whatever has been discussed so far. So if you have a question, you have an input you want to make based on whatever I've said or discussed today, you can bring it up before we go into our questions. Okay. Remember, I said that when it gets to my questions, come up with your answer. My questions are always not difficult. Sometimes one or two ones that few of them that I be more like, but they are always easy to deal with. Okay, so let's try to come up with what we call our contributions when it gets to my question section. So this is my first question, but if you have a question, the floor is still open for questions. You can put a question in the chat section. I'll read it out and try to attend to it. But if you want to also speak, I will mute you and then you come in to also ask your question. But then we'll try to address it, if not by myself. All of us here, we're about 92 here. So this is a huge class. Imagine that you are standing in front of 92 students and then talking, or colleagues. So that's not easy. So it means that we are huge. We have a huge number here. That's good. So yes, Madam Mary, have to unmute you. So I think I've done it. Yes. So Madam Mary can ask to unmute. Hey. Yes. So go ahead, Madam Mary. I've done it.
Thank you very much. The question says that what somebody is having severe panic attack. So the A says
okay. Then read the question for us, Madam Mary. Then we go through.
A client is experiencing severe panic attacks. Which nursing intervention would meet this client's immediate need? Meaning most of them are the needs of the client, but which one will meet the severity of the attack that the client is having right now? Teach deep breathing relaxation exercise. It's a need, but I don't think it is now. Place the client in the Trendelenburg position. No, it's not even part of the option. C, stay with the client and offer assurance of safety. I think I'll go with that one. Administer the other PRN, that one will not now. So the C takes priority. Thank you.
All right. Thank you. I'm getting someone going for A. Mr. Paul, tell us why you're going for A. I will mute you. Come up. Let's hear from Mr. Paul. Sometimes I always want people with varied views. So Mr. Paul, come up. Raise up your hands so I can see you, so that you tell us why you're going for A, Mr. Paul. I want to hear from you. Why are you going for A? Okay, let me unmute you. Done now. Yeah, it's really the way they set my Zoom for me. Should be done by now. Okay. Yes, it's done now.
Okay.
So Mr. Paul, go ahead.
Boss, the question is an action of immediate need. What can be done immediately to relieve the patient of the panic? And we all know when we are in anxiety and those sort of things, when we do deep breathing exercises, it releases us from the anxiety we are going through. And the option 2 is saying that stay with the client and offer reassurance of safety. If I stay with the client, will it relieve the client from the panic attack he or she is going through? That's why I chose the A.
Okay. All right. So Mr. Paul has given us his all right. He has given us his rationale for going for the A. All right. So I only wanted to hear from him why he's going for A. And he thinks that someone says no distraction too for today. So we like it that way. All right. So Madam let's hear from Madam Amma, then we will show our answer for after we did it. So yes.
I would also go for C because teaching somebody deep breathing and relaxation exercises when the person is at the peak of a panic attack. That person might not even listen to you. They will not even get the impulse of what you are trying to tell them.
Okay.
So I think that staying with them and reassuring them will kind of calm them down. Then the deep breathing relaxation exercises will come.
Okay. All right. I think we can make progress. Okay. I mean, we've all, brought in, but just like this, safety staying with your client at this point is the key. Okay. So you need to make sure that you are staying. Yes, the deep breathing relaxation techniques at this point is needed, but the safety is always the key. Staying with your client. Okay. So stay with the client and offer reassurance of safety. At this point, severe panic attack, the nursing intervention, which nursing intervention will meet this client's immediate need is to provide what we call safety at this point. Okay, staying with your client, the offering yourself for support. That is the best answer here. Okay. All right. So I think we all understand and agree to this. All right. A client is prescribed apraxolam for acute anxiety. What client history would cause a nurse to question this order? A history of alcohol dependency. B, a history of personality disorder. C, a history of schizophrenia. D, history of hypertension. Yes, I haven't done medication, but I did talk about, anxiolytics. So if you were with us from the beginning when I started and I talked about anxiolytics, we should be able to answer this without any problem. Okay. Without any issue, should be able to go around this and then get our answers and everything set. Yeah. So I believe we all agree that A is the best answer here. Okay. Remember, we said that anxiolytics, one can abuse anxiolytics. Okay. And so if you are giving anxiolytics, to a client, and the client has a history of dependency, you need to report that to, dependency on other medication or other drugs, or the client's a known drug abuser, you need to report that, because the chances that the client will abuse the benzodiazepine is very high. So that is one thing that we need to take note of when giving what we call anxiolytics to a client. Yes, let's make progress. All right. A student has been diagnosed with generalized anxiety disorder, which are the following symptoms should a campus nurse expect this client to exhibit. It's a SATA. 1, A is fatigue, B is anorexia, C is hyperventilation, D is insomnia, E is irritability. Who would want to answer? If you want to answer, you can raise your hand up. I will mute you, and then you come in with your contribution. Madam Mary wants to come in. Let me unmute her.
Hello. Okay, thank you. And we said generalized anxiety, they will experience fatigue, hyperventilation, then insomnia is part. Let me see the E. I'm not seeing the E well.
It's irritability.
Irritability too is part. Anorexia is not there. I'm not seeing anorexia.
Anorexia is not there.
Yes, please.
So you are going with
A, C, D, E.
A, C, D,
D,
E.
E.
Okay.
Yes.
So Madam Mary, okay, thank you, Madam Mary. Madam Mary is going for A, C, D, E. Do we agree? Or someone want to take some out? You want to stay, if you want to stay from any form of plus or minus one issue, you go with what you trust yourself, okay, or what you think is the correct. That is what I always say with SATA, in order to avoid deductions. If we are not sure, but always that if you are confident and sure of your answer, go for it. Okay, that is one technique that you should have with regards to SATA. So ADE, that is fatigue. Then we have insomnia and then irritability. Hyperventilation, it's not part of generalized anxiety disorder. Hyperventilation is when we talk about what we call severe and then panic attack, panic level anxiety. That is when we talk about hyperventilation. But hyperventilation itself is not part of the criteria. Remember, I gave you symptoms you should look out for with generalized anxiety disorder. I gave you about 3, 4, 5 symptoms. We said that at least three of them must be available or must be present, 3 or more. Okay. Yes, there's a handout. Madam Doris.
Hello, sir.
Yeah, go ahead.
So in this case, if you answer only one, will you still be deducted?
No, so you get 1 out of 3. The possible answers are 3. So if you answer 1, you get 1 out of 3.
So in which case would you be deducted when you?
So like Madam Mary went for 4 options, I thought, but the correct answers are 3, but she went for 4. So in that instant, they will deduct the wrong one from the 3 correct ones, and she will now get 2 out of 3. Are you getting me? I believe you understand what I said. So if the possible answers are 3 and then you chose 4, they will deduct the wrong one from the correct one. Okay. And then your total answer or correct ones will now reduce to 2. So you now get 2 in terms of the marking to be 2 out of 3. Okay. So ADE is the correct answer here. Now let's look at this question. A nurse has been caring for a client diagnosed with generalized anxiety disorder. Which of the following nursing interventions should address this client's symptoms? Select all that apply. A, encourage the client to recognize the signs of escalating anxiety. B, encourage the client to avoid any situation that causes stress. C, encourage the client to employ newly learned relaxation techniques. D, encourage the client to cognitively reframe thoughts about situations that generates anxiety. E, encourage the client to avoid caffeinated products. I believe we are still going through, so I'm waiting for us to also produce our answers. So who would want to talk for us? I'm getting different answers. That's what I want. ACD, ACD, ACDE, ABC, BCE. Who is talking for us? Those of us giving us the answers. So someone should tell us. Raise your hand. I call you, and then you call me. If not, I'll call you. I'll call you. If I go through the answers, okay, let me go through the answers and call someone. So the person tell us why he or she is going for. All right. Akam Abigail, you are the last person who have answered. You are going for B. You are going for B, C, D, A. So you attend it instead of the A, B, C, D. Okay. So tell us why you're going for A, B, C, D, Madam Akam. Raise your hand so that I'll see you to unmute you. Okay, I've seen you. All right, I think I've done it. Should be unmuted by now. All right. So let's hear from Madam Akam. Why?
Yeah, so I took a we said that encourage the client to recognize the signs of escalating anxiety. So you have taught the patient the signs that will show when her anxiety level is going up. So the moment she starts experiencing those.
Oh, she's gone off. Or is it my end? Madam Akam, we cannot hear you again. I like the way she started her submission. Okay. Let's hear from Mr. Paul. Madam Akam, your line, I don't know what happened. But if you are able to reconnect, I will let you continue. But at the moment, Mr. Paul, I'm unmuting you. So Mr. Paul is done. You can continue.
Boss, I will go for the A, C, A. We're having, okay, A, C, D. So the A, encourage the client to recognize the signs of escalating anxiety. So if the client is able to note those factors that lead to anxiety, I think it will help. And the B, encourage the client to avoid any. I didn't choose B because of the word any. I see it to be a first word. That's why I didn't choose the B. Then C, encourage the client to employ newly learned relaxation techniques. It can be that the client is using some old method that is not working. So if they are able to get new ones, I think it will help in relieving them from the anxiety situations. Then the D, encourage the client to cognitively reframe thoughts about situations that generate anxiety. I see that one to be more of cognitive behavioral therapy, if I only understand it well. So that's why I chose the E. I'm not sure if caffeine have effect on anxiety. That's why I didn't choose the E.
Okay. So you are now playing safe game with the E, right? But you're not too sure. I think that's okay, fine. That's correct. Okay. That's good. I'm not saying it, I mean it's not part of it's part, but I'm just saying that if you are not sure, stay away from it. Okay. There is another hand from yes. Try to use your name, okay? The one using the number. So I've unmuted you. It should be done by now.
Sir,
Yes. Yeah, hello.
he said today, dear. Not talking. Quiet class.
Yes. It's how the meeting was set. So, but I think it's fine too. So
So it's fine, but it's making us distance from you.
yes, I understand. So
Sir,
you want to, yes, go
so
ahead.
the A is okay. Encourage the client to recognize the signs of A is correct. C is correct. Encourage the client to employ newly learned relaxation technique. D is also correct. So for me, the year I'll go for it. Even though you didn't mention caffeine in any part of your lecture,
Okay.
we all know caffeine is related to how do I explain? It brings it's a factor in anxiety development or generates it.
Okay.
I'll later give you my.
I get you. I get you where you're going with the
And
E.
then said the B2, you know, even though it says encourage the client to avoid any situation that causes stress.
Yeah.
For me, sir, I want to go for all the 5. Although I want to play safe, I want to go for all the 5. B is a bit general, but stress can also, you didn't mention it, but stress can also play a big factor in developing anxiety. And then the E. So me, I want to take the risk and
So
add
you want to go for
all of them.
All right.
I just want to take the risk. Thank you.
All right, thank you for your contribution. So, in fact, the B is not part. Okay. Just like Mr. Paul said, the word avoid any, that's an absolute statement. Remember, McKay said that an absolute statement always make an option wrong. Okay. The moment you have an absolute, yes, there can be an exception, but almost all the time, when you have an absolute statement, okay, it mostly makes the option wrong. So the moment you have any there, like Mr. Paul said, I mean, it makes that option outrightly wrong because of that absolute statement, over there. So you always have to take note. Those are some of the techniques you can be developing while answering your questions. Okay. Yes, and even though this client is having anxiety, the client should be exposed to the fears when the client is ready for. But if you say client should not be exposed to the fear at all, then you are not helping the client. Remember, I said expose the client to the fear when the client is ready for to learn and then cope with it. Okay, so avoiding if you read the last part of this rationale, it says that avoiding the situation that causes stress is not an appropriate intervention because avoidance does not help the client to overcome the anxiety. So you need to expose the client at the point when a client is ready to learn from the situation and cope with it. And like I said, that absolute statement there, the use of the word any makes that option wrong. All right. So I think we are good with that question and then the answer as well. So it's supposed to be A, C, D, E. Okay. All right. A client who is a veteran of the Gulf War is being assessed by a nurse for post-traumatic stress disorder. Which of the following client symptoms would support this diagnosis? It's a SATA. So A is the client has experienced symptoms of the disorder for 2 weeks. B, the client fears a physical integrity. The client fears a physical integrity threat to self. C, the client feels detached and estranged from others. D, the client experiences fear and helplessness. E, the client is lethargic and somnolent. So let's analyze the question very well, come up with what we think is the correct answer. Am I getting people answering? Okay. Who's ready to attempt for it? Yes. Is it difficult? BCD. B is just going for BCD. Fear of physical integrity. If the client fears a physical integrity threat to self, then the client feels detached and estranged from others. The D is client experiencing fear and hopelessness. Okay. I'm just reading out those who are going for the option BCD.
It can mix. Who's ready to defend his or her answers? Or we all fear to talk? Okay. So the BCD is correct. Okay. The BCD is the correct options here. All right. A newly admitted client is diagnosed with post-traumatic stress disorder. Which behavioral symptom would the nurse expect to assess? Which behavioral symptom would the nurse expect to assess? 1, recurrent distressing flashbacks. 2, intense fear, helplessness, and horror. 3, diminished participation in significant activities. 4, detachment or estrangement from others. All right. Madam Vivian's hand is up. So let me call her. All right. Madam Vivian, I've unmuted you.
Okay, so please, I want to ask question from the previous one. The previous question, please. Why is number 1 not correct?
What was this? The number 1. The number 1 says that client experiencing symptoms of the disorder, it is not time bound.
It's not time bound.
Okay, it is not time bound.
Yeah,
Okay, it's not time bound. So that is why. Cannot
Okay,
happen
thank you.
at any point in time. So the moment you are associating it with time, it makes it wrong.
Okay, thank
Okay.
you.
All right. Yes, this very question, please answer it for us. A. All right. Laughing like Kella. Why are we going for A? I'm interested in that. Yes, Mr. Paul, let me unmute you.
Okay, boss. In post-traumatic stress disorder, I see the hallmark is flashbacks. The hallmark is flashback. That's why I choose option A.
Okay. All right. All right, thank you. I want someone else to talk. Look at what the question is demanding from us. Read the question again. I want us to think about the question. Don't think through the question, okay? But just look at the question, analyze the question. Look at what the question is. The question is that which behavioral symptom? That is what your attention. That is a key word here, behavioral. Okay. That is what you should watch out for. So, Mr. Paul, I'm not agreeing with your one. And it's not, yes, I'm not agreeing with your one. We are looking out for behavioral behavior. All these things are part of, PTSD. All the four, they are all part of, assessment findings for PTSD. But we are looking at behavioral, which of them, it's like a behavioral thing that the client is showing. That is what the question is demanding from us. Okay. So this is it, okay. Yes, Zaisi, you wanted to come in. I don't know what Zaisi wanted to say, but let me unmute him. So as whether he was also going for the 3 or different one. Zaisi.
Yes, I was going for 3 and 4 because they seem
it's not that
similar. Yes, but looking at the behavior, there's an aspect of it.
Okay.
Diminish participation and significant activity. Let me see the last one, the 4.
The last one is detachment or estrangement from others.
So are they not the same? Detachment or estrangement from others? Is it not the same as diminished participation and significant activities?
No, this is significant activities is more than detachment. Detachment is I don't want to go near anybody. Okay. But
So that's your behavior.
Diminished participation in significant activities is like everyday activities you have to do. Activities of daily living and other important activities you need to engage in. Okay.
I agree with the 3, but then I agree with the 3, but then
you are still thinking about the 4.
The 4 too. That's behavior.
All right, the best answer there. The English always say the best answer there. Okay, it's that one. Okay. So I've already seen people are dropping out. Yes, our time is up. So I would like to end the class here for today. We need to.
Okay, we'll go and pray.
We need to respect our time. Even though we could not start it, I think we started around 14. So it's okay. We leave it here, and then we can meet tomorrow, God willing, and then continue from there. But before that, if you have anything you want to bring it on board or say.